very good teacher.
Srilata is a very favorite junior of mine. So, and we've known each other a very, very long time.
So many. Shall we start now?
Yeah, I think we
People
can.
are joining just now. That's why.
Good evening, sir.
Good evening, sir. Lalit sir.
Good evening, sir. How are you, sir?
Fine, fine. How are you?
Fine, sir. Good evening to all.
Good evening, sir.
Lalit sir is President ISA Rajasthan.
Wow.
I'm very happy to see here, in spite of his busy schedule as principal.
Just days to home.
Yes. So nice. So we're all very much, now interested to listen.
Okay.
So we will start now. I think time 6:33.
I think we'll start it off.
Yeah. So welcome to ISA Telangana webinar. As usual, some delay was there last month because of so many busy schedules. But again, we are on the track now. We have two speakers for today. Dr. Aarti Jama, she is from Latur, Maharashtra. She will make us fit today. And other speaker is Dr. Srividya. She will talk on brachial plexus block. And welcome Dr. Ratnakar sir, our President ISA Telangana. Dr. Lalit Kumar Regar sir, President ISA Rajasthan. And Dr. Avinash Bhosle, Honorary Secretary ISA Maharashtra. And Dr. Srilata, today's coordinator. So I request Dr. Srilata to take over the session.
Thank you, Dr. Ramakrishna. Today we have some offbeat topic apart from anesthesia. And this is very important in anesthetist life per se, especially after COVID. Like everyone is into some or the other thing to de-stress themselves. And this is actually the curriculum and extracurricular activities. It should be like both coexisting for us. So we know we are all busy in our anesthetic perioperative management per se, but at the same time, we all need to give our time for this extracurricular activities, not only exercise, but also a part of socializing and also in the relaxation, like yoga, swimming, and music also carries very important part in our life. So we need to balance that work life and socializing and exercising. Like it should be a part of your life. So I think the best one who can deliver a lecture on this will be none other than Dr. Aarti. We all know Dr. Aarti. She has received Hall of Fame award also for the same purpose. And she is the consultant in Vivekananda Hospital. And she mainly practices onco anesthesia. And she also is interested in difficult airway management per se. So we have the speaker, Dr. Aarti. She doesn't require, I think, much of recognition. But
her photos,
very, very happy to have Dr. Aarti as the first speaker.
Her picture says a lot of things. She's a marathoner and as well as yoga specialist. You can share some of your photos also in the talk.
Yeah,
sure, sir.
Get fit, don't quit. The topic is get fit, don't quit. Yeah, it's the topic is yours. The stage is yours.
Okay, ma'am. Fine. I'll just share the screen. Okay, is my screen visible?
Yeah.
Yes.
Okay. So first of all, I would like to thank you everyone from the ISA Telangana. I would like to thank our secretary sir and our president sir for giving me this opportunity to speak for ISA Telangana. This is definitely a big opportunity for me to go out of Maharashtra and have a talk with you all. I hope after my talk, many of you will get motivated and you will start your fitness journey, because I am also among you who was never in sport, who was. Hello? I hope I am audible. Okay, sir?
You are audible, but some disturbances is also coming.
Disturbance is coming?
Yeah. Some.
No. I have muted. Someone's mic was on. I have muted.
Okay. Because here it's all sound.
Hmm.
So we being anesthesiologists, we are always busy. We always run ahead of time. We are always on our toes. And definitely we don't have any fixed working hours, long hours, night hours. And we definitely excel academically, incredibly. We are detail oriented, skillful at every procedure, calm in all situations, and caring for the anxious patients. But among all these things, we need to take out time for ourselves, because to take care of our health is equally important. And that's why today I am here. How I started my journey and how you should commit yourself for your healthy well being, because healthy well-being is equally important for your physical and mental well-being. So we all are getting diverted along with our busy hours. Our hourly tea comes in our OT, we get snacks, lot of fast food, lot of parties, socializing and all these things, sometimes out of desires, sometimes out of cravings or temptations, but we keep on eating junk food that is really not good for our health. We being doctor, we all know about our requirement, our calorie overloading, but some and other way we are not able to stop it. These things are really addictive, and along with sedentary lifestyle, fast food, and no, more busy lifestyle, we are doing everything else than our exercise, so we are not prioritizing ourselves. So we need to focus on this, that along with work life we need to have a balance with our fitness also. So how to adapt all these things, fitness and health, these all both goes hand in hand. For better quality of life, for lower stress level, and to have a disease free life, we need to focus on fitness. That will enhance our performance, it will improve our appearance, we'll get a natural beauty. The sweaty body gives a more beautiful face. It improves your flexibility and it helps to tone up, it helps to preserve your muscle mass. So let's start. So from where to start? Each one is having different idea of fitness. Everyone is not always comfortable with running or yoga. Like sir told me that even meditation is one of the way of keeping yourself calm, or keeping yourself engaged in some of the fitness activity. So you can start your fitness journey from anything you are comfortable with, or what you love, or what the things or surroundings allow you to do. You can go for yoga, cycling, walking, running, swimming, calisthenics, resistance training, bodyweight exercises, anything. But please, whatever you start, I would say that stick up to it. Whenever you start, promise yourself that, yes, I am going to take care of my body. And at least 4 to 5 days a week, I am going to start some kind of exercise for myself. I was non-sportive person, and my fitness journey started with running. Yes, running. Why I choose running, and why I will ask everyone to choose running as an exercise or walking as an exercise, because it is one of the exercise that anybody can do, either youngster or oldies. Anyone can start with running if you train it properly, if you start taking care of your muscles, your strength. You can run solo, you can run with your partner, or you can have a group. It's always better to run with your partner or with a group. If partner is your spouse, that is much better, because someone is definitely needed to kick you out of the bed, because that is the only challenge कि सुबह मुझे उठना नहीं होता, I can't get up early. So once you get up, then you can do anything. And obviously, you are smart enough to do that. You can do anywhere in the world. Even if you are on vacation, for family vacation, for conferences, or for anything else, start your day with your exercise. Commit yourself for 15 minutes to half hour daily, and do your exercise wherever you are on the back of the world. You can do it at any time, morning, evening. If you are having gym facility, definitely in noon hours or so, you can do your exercise. Running doesn't always need trainer, not at least for beginners. Yeah, if you go for advanced level, you might need training for a improvement in running. But initially, you don't need any trainer. Gym is not mandatory. You need least gears for running, and it is less dangerous sport. Don't limit your challenges. Challenge your limits. Whatever kind of exercise you adapt, you need to improve in your exercises. So you have to keep small challenges for you. Keep small challenges like I'll do daily 1 minute plank for 30 days, or I'll go for 3 sets of 15 squats daily for 21 days, or 10 squats of 3 sets for 10 days, or anything like that. If you keep small challenges, you will motivate yourself. Or you can like go for challenges like आज till I complete my 10,000 steps, I won't sleep. Then you can go for spot jogging, spot walking, or you can move around every 5 minutes in a for every hour, or divided whatever you are comfortable with, either in morning, evening, afternoon. But keep some small challenges, keep some goals for you, so that your fitness challenges will be continued. And if you keep these fitness challenges along with your friends or family, you will be motivated with each other. Like आज तुमने कौन सी साड़ी पहनी, कौन सी मैंने पहनी. The same way, how many steps you walk today, how many I did. You can compare these things and keep a goal among yourself. You can dedicate some activity on occasions. You can do some exercises, or some distance walk, or some yoga, and you will say, this I tried for your birthday, for your anniversary, and this is my fitness gift on your special occasion. So is it self-care? Is it selfish? No. Once you get into fitness, you'll start taking off so many parameters. You'll start taking care of your nutrition, your hydration, your sleep. You become conscious about partying. Like if you want to get up early for your running or for your exercises, you'll try to come home soon and go to bed early, so that you can get up with a adequate sleep. You need to take care of hydration. So always carry your bottles with you wherever you are there, in OT or at home. Keep water bottle filled, so that you can sip it in between, and you will have a proper hydration throughout the day. Nutrition. Obviously, when you start taking care of yourself, you start taking care of your macros and micros, like your protein intake, your carb intake, fat intake, in short, your calorie intake. And you try to consume as healthy food as possible wherever you go. Obviously, to munch your favorite food is possible if you take care of your daily nutrition. Early to bed, early to rise. This is definitely helpful. It gives you ample of time for yourself, for your work, and for your exercise. You have to focus on your strengthening exercises, because many people say that because of running, because of walking, or this and that, I'm started getting knee pain, ankle pain, shin pain, or something. This is because you are doing random exercises. You are not focusing on strengthening exercises. I'll say, whatever it is, backache or any other pain, if you strengthen your muscles, that muscles will decrease pressure on your joints, and you will get rid of all those aches and pains. Equally, stretching is important. Opposite muscles, we need to have a proper stretching, so that with a similar activity, they will not get in contracture. And all these things together lead to your healthy lifestyle. So eat everything in moderation. I won't say that don't eat pastries or don't go for pizza and samosa. Eat everything, but eat in moderation. See that your tummy doesn't come out. Learn to balance your nutrition pyramid. Focus on your calorie intake. If you know what calories are required for you, what macros are required for you, automatically your micronutrients will be fulfilled, and your meal timing and frequency will definitely help to improve your nutrition. So supplements are least required if you are taking your required nutrients from your natural diet. So again, as I said, exercise wherever and whenever you get time. Yes, you can exercise in OT also. You can use bandages, saline bottles, wall for sit-ups, or anything accessible. Once exercise in your mind will run around the other things in the same way, and you will start doing small stretches in between your cases. So small 5 to 7 minutes break are also important to relax your body and to keep you flexible and to maintain your strength. So again, how to stay motivated? So if possible, try to fix a regular time. If you can have a buddy, or you can do some yoga classes, online classes, I say, or if possible, you can go to gym if you are having that time to transport to the gym and all. But have some fixed regular time, either morning or evening. As if I prefer running in the morning because weather is pleasant in morning, and I do my yoga in evening hours. Now after my session, I am definitely going to complete my today's yoga session. So the point is that fix a regular time so that you will keep yourself motivated. Ki, now this is my exercise time, and these 45 minutes are for myself. All other time I'll be doing all other chores. Keep it short and sweet. It's not always necessary that you should go for 1 hour or 2 hour workout. You can do for 15 minutes, 30 minutes in morning, or 15 minutes, 30 minutes in evening, or whatever is feasible. But start your exercises. Slowly, you can increase the duration of exercise. Keep a goal. Like you can say, yeah, I want to run 5 kilometer run, or 10 kilometer, or 42 kilometer, whatever your target is. Accordingly, you have to decide what mileage you will be covering in your this week, or in a fortnight, or a coming month. And accordingly, you have to schedule, you have to plan out your workouts, and better if you write down and just stick it. Yes, I did this as per my plan. So this will keep you more focused, and your goal will be easily achieved. Sign up for a challenge. Keep small challenges always. Like, I want to learn push-ups, but I'm not able to do push-ups. Okay, I'll start with a new push-up, knee push-ups, wall push-ups. These are the easier versions. But from wall push-up, you can come down to knee push-up. From knee push-up, you can come down to a 1 full push-up, 5 full push-up, and this way you can improve your strength or your flexibility by keeping up small challenges. Always better if you are having a buddy. But if you don't have a buddy, don't wait for anyone. Start your exercise. So, what is the truth about maintaining fitness? Yes, if you are in fitness, it's not like कि 6 month का package लिया, 3 month का package लिया, and everything is done. No, you have to be in fitness throughout your life. It's the same like our body needs food, water, and other things. The fitness or exercise is equally important. The work doesn't end when you reach your goal. You have to keep on doing some stuff to maintain your achieved fitness. You can't go back to your old lifestyle unless you want the result of that lifestyle again. Once you know your thin, slim body is looking more beautiful, you really don't want that obese body again. In short, your fitness is rented in your body. By eating right and working out, you make sure to pay the rent every single day. So it's always good to move slow in your fitness journey with a sustainable plan. Build habits along the time to hold the results. So those who have a passion for it, they know the pain is temporary. The accomplished feeling lasts longer than just an exercise. So exercise your brain, keep learning, keep reading about it, and try to implement new exercises so that your exercise won't get boring. So this is what I want to say. Whenever you start your exercise, even if you are beginner, many say that I am a beginner, I don't have naturally flexible body, or I don't have certain body shape so that I can go for such advanced yogas. These all are misconception. I started my yoga practice in COVID because outdoor activities were restricted, and these are the results of consistency. So I would again like to say that yoga is an inclusive practice for those who show up. So prepare yourself and start working on your yoga poses, balance, flexibility, and strength. By addressing these areas regularly, you will definitely keep increasing or keep preparing your body for new challenges. And along with you, even your family will start having a healthy lifestyle. So always goal to be better today than what you were yesterday. Try to improve yourself and enrich life. I am running my own race. I'm not running for any podium or for any competition. Nothing. I'm doing running for myself because fitness is for myself. So don't compete with anyone, but compete with yourself. Try to improve yourself and try to implement a good training plan. So this is my fitness journey. If you don't come from a healthy family, make sure a healthy family comes from you. That's it. Thank you so much.
Beautiful lecture. I congratulate Dr. Aarti. It is so inspiring and motivating also. Thank you.
So much.
Thank you, Dr. Aarti. And that is a nice one, that we don't compete with others. We need to compete for ourselves. So that's like everyone, like we need to judge ourselves what is best for us. And also at the same time, many of senior ones are like, we need to respect our age also, at what time, what to start and what not to start. That is very important. And also whoever is interested in whatever, like dancing, music, so they need to go on with that. So thank you very much, Aarti. It's a very inspiring one. And
Thank you.
yeah. And
Probably we should start with 1 kilometer running and then slowly increase,
1K,
because we are
1K,
all
2K.
only walkers, not runners so far.
If for running, you definitely need a good strength, sir. And not
Mm.
directly 1 kilometer. Even I will say
Mm.
that you should start with 100 meters or 200 meters. Because
Okay.
100 and 200 meters is also challenging. And
Mm.
running is not always about the fast running. You should start with a slow jogging so that
Brisk
you
walk.
will not get fatigued, you will not get tired, and you will be prepared for your next day run again. So I always say for the beginners that run pole to pole, like a 50-meter
okay.
run, 50-meter walk, 50-meter run, then gradually increase it so that you will not get tiredness, fatigue, or any sprains and strain your muscles
Mm.
or any ligament injury.
So in the rainy season, how do you manage this running and all? Because everything, outside is very difficult.
Obviously, if it's raining heavily, we don't run. But with a sprinkle, we go out. In drizzling rain, it's a beautiful experience. So we run. Sometimes it's very hot and humid. We go for slow runs. So in running also, we are having different schedules. Like some day we are having interval runs. Some day it's a tempo run, long runs, hill runs. So it depends on what our schedule is. But rain doesn't always stop you from running.
I find some excuses.
so if you want to find
Thank you.
excuses, you'll find excuses. That's it.
Always. Always.
Yeah, I'm happy that I've moderated this. I'm also happy to say that I also do some amount of yoga, and I have the other thing I'm happy to listen, that always try to learn new things. So now I'm learning tennis, so it's very good, and
Yeah.
swimming, yoga, running, walking, everything, like dancing, music. So we do a lot of things, and happy that Dr. Aarti is another inspiration. Yeah.
Thank you.
I request our audience also to share their experience briefly. Whatever the activity they do, that will be inspiring to others also.
I think there's some.
If anybody wants to share their experiences regarding fitness and exercise.
In the chat, it's like one of them has written, Dr. Lalit, he has a nice presentation, and Dr. Seema has written, yes, we have to start. Very well presented. Thank you, Dr.
Thank you. Thank you so much.
Yes,
Can we
Dr.
go for the
Amrita.
next one?
Yes, yes, sir. Divra sir. Yeah.
Yeah. I am also a staunch supporter of this exercise. For the past 30 years, I have been playing shuttle badminton plus swimming. Past 30 years. What I have observed is, along with your exercise, whatever exercise you do, in whichever you do, you will have a feel-good factor from inside, and you feel energetic from inside. And the most advantage what I felt was your work efficiency also increases at your workplace when you do good exercise.
Definitely.
This definitely has its impact on the whole day. If you do an exercise in the morning or in the evening, your thinking power increases, your work capacity increases. That is the main advantage.
True, sir. True.
Yeah. So I have been doing this regularly for the past so many years. 1 hour of shuttle badminton playing, and then after that swimming. So that it helps me in a lot of ways, not only in the health aspects, in other words also. When I go with the family to swimming and all, the bonding of the family also increases. Family with the children, family with the grandchildren, everything matters a lot.
That's very true.
I always say that you are always charged. Your battery doesn't get
Yes,
discharged.
always charge. Yes, always charge.
And the other
Yes.
thing is that maybe post-retirement, we'll have some extracurricular activities in our hands to pass on the time also. That is
Yes.
also very important. That's
Yes.
going.
Actually, nowadays, no retirement.
That is true.
It depends on you how much money you want to.
And as age progresses now, we get sarcopenia. So it's weight training or resistance training is really important for each and everyone. Even if you start at the age of 60, it's not always necessary that you should lift heavy weights. Even with a small 1 kg or 2 kg dumbbells, you can start with your exercises. That much is also enough to preserve your muscle mass. Even if you are traveling, you can carry your resistance bands or your thera bands along with you, and you can do your weight training in your travelings also. Because as I said, that 15 to 30 minutes is really not tough time to take out for yourself. If you take our screen time, we are more on our screen time also. So we can cut short our screen time and we can go for bit of exercises. I will not always say that go for all the hard exercises or strenuous exercises. Go for easy exercises with the easy movements, but do something for your body daily. Promise
Thank
your
you.
body that I'm going to take care of yourself.
Yeah.
Thank you.
Thank you.
Thank you, Dr. Aarti. I think everyone will take a pledge that everyone will start doing exercise. So we'll go to the next on-beat topic of anesthesia. I think if everyone goes for voting, like which is the most common question usually encountered in exams, I think one of the questions will be like brachial plexus block. I think most of us will agree. And we know that brachial plexus block is the most common regional block. Everyone everyone has done in their own faculty career, PG career. And it's a very important topic for the PGs right now. They should understand that there are some tips and tricks for this brachial plexus. And it is like a never dying topic. So, and the other important thing is we need to know more and more, because we need to know the roots, the trunks, the chords, everything, the divisions at what point, how to go more precise with ultrasound techniques. So you need to learn more and more about it. And Dr. Srividya, she is going to talk about this, the bulletproof brachial, that is improving accuracy and decreasing complications. So we have our second speaker, Dr. Srividya from Tata Hospital. She's a senior consultant over there, and she is like mainly into interventional pain management. And she has got a lot of publication also PubMed with PubMed indexed. Those are PubMed indexed. And she's She's also got interest in other interests are regional anesthesia, obstetric anesthesia, and labor analgesia, and other infection control practices. So we have Dr. Sri Vidya as a second speaker. Sri Vidya.
Welcome.
I hope I'm audible. Thank you, Srilata. And it is very nice to be amongst all of you, Dr. Ramakrishna Reddy, and all of you all to be addressing the Telangana state. I do have many friends there in Telangana. Srilata, of course, is one of the oldest, and of course, I have made many new friends there. So,
and just to add one thing, Dr. Sri Vidya is a very good singer.
Okay, thank you for a very kind introduction. And just before I start off, I really need to compliment Dr. Aarti. Her talk was totally inspiring. Very for a person who is not so much into fitness and not so much into, and most of my stress busting comes from my music. So that was really very inspiring, and I'm sure need to start working on what I want to get doing in terms of staying fit. So with that few words, I'll just share my screen.
Yeah, go ahead.
So I hope my screen's visible. Is my screen visible?
Yes. Yes, ma'am.
Yeah, it's visible.
Yeah. So today, Srilata, when she called me, she said, so can you speak something on, which the postgraduates will be interested in? And I thought, of course, what would be more appropriate than to speak on brachial plexus block, and which probably is one of the most common things that we learn throughout our undergraduation, and then when we go into in our post-graduation, and then we go into practice. Of course, this is one of the most common things that as anesthesiologists that we would do, and this never goes out of fashion, so every day something new comes up, something important comes up, and every day one gets to refine his or her own techniques, so that in order to, as young anesthesiologists, when you're a fresh postgraduate and you've done a successful block, I think the endorphin release would be as high as what you would get after a run that Dr. Aarti just recommended. And I'm sure that would be one of a very happy days in your life. And if you can remember that, the feeling that you get as a young postgraduate. So just moving ahead with the topic, just to recapitulate a little bit, which we generally, get at the beginning of our anatomy class, which we learn. So everybody is quite familiar with this the diagram that I've shown here. The brachial plexus is from the anterior primary rami of C5 to T1, sometimes roots from C4 and also T2 join in, but we really don't need to go into such details, but we must know as to where the brachial plexus originates from. So the C5 and the C6 join together to form the upper trunk. The C7 goes as the middle trunk, and the C8 and T1 goes together to form the lower trunk. So superior, middle, and posterior trunk, if you would, and inferior trunk, if you would talk in a perfect anatomic parlance. Thereafter, each trunk would divide into divisions, the anterior and the posterior divisions. The anterior divisions of the upper trunk and the middle trunk would then become joined together to form the lateral cord here, which is here. The anterior division of the lower trunk would continue to be as the medial cord, and the posterior divisions of all the three trunks would join together to form the posterior cord. And thereafter, continuing onwards, it will turn into branches. So the branches, a few of the important branches are enumerated here, but we all know, we all had mnemonics to remember all our branches. So from the lateral cord, you can take it as Lucy loves me. So that would be lateral pectoral nerve, lateral lateral cord of the median nerve and the musculocutaneous nerve. In the medial, the medial cord would give, you could say, most medical men use morphine. I hope they use it on the patients and not on themselves. So that would be MMMUM. So that is medial cutaneous nerve of arm, medial cutaneous nerve of forearm, and medial pectoral ulnar nerve, and the medial root of the median nerve. So that is what the branches are from the medial cord. And the posterior cord, of course, is the ulnar, where you can see here, though the ulnar nerve doesn't come from the posterior cord, but the mnemonic there is ulnar. So that is upper subscapularis, lower subscapularis, nerve to latissimus dorsi, the axillary nerve, and the radial nerve. So the important branches are all covered. So let's take a look at what are the methods by which you can block this plexus. You can take the interscalene route, you can take the supraclavicular route, you can take the infraclavicular route or the costoclavicular route, and also the axillary route. So when you look at where if you suppose do the interscalene, if you take the interscalene route, generally you will be blocking at the area of the roots. Then if you take at the supraclavicular level, you'll be blocking at the level of the trunks. If it goes costoclavicular, mostly in the divisions. At the infraclavicular level, it will be the cords. And at the axillary level, the terminal branches will be blocked. So the more cephaloid you go, the more denser is the block, and the more the more distal that if you block. So obviously one has to be more accurate and in getting all the divisions right and all the branches right, and that is when you get a more accurate block. So at the interscalene level, if you block, you will get mostly the upper part of the shoulders, and the upper forearm will be upper arm will be covered. At the supraclavicular level, of course, below that, the elbow and some part of the forearm. And for if you want to get into the wrist, and of course, you can also block from the supraclavicular level by blocking the medial cord. You can get up to the wrist, and at the axillary level, the areas of the wrist and the lower forearm are best blocked. So there are many methods to doing this block, and we are all aware of that. So it could be either landmark technique, or you could be using a peripheral nerve stimulator, or you could be using an ultrasound guided, and more so you could be using a dual technique where you could use both the peripheral nerve stimulator and the ultrasound guidance for doing this block. So what do you mean by a bulletproof brachial? So what I interpret as a bulletproof brachial is that the block should be an effective block, and there should be no or just about minimal complications. So in order to achieve that, let's look how can you get an effective block. So if you want to do an effective block, let us look at what the literature says. And the best of hands, the people who've just been doing landmark technique. I wouldn't forever say, because my professors all did landmark technique, and I also started off doing that. So the success rate, and as I practiced, of course, success rate improved. And the literature has mentioned success rates as high as 98.5. But if you look at the complication, let us look at the complication rates. The complication rates are also equally high. So that it could have, you have an incidence of phrenic nerve palsy, which is about 45%. Of course, a Horner syndrome, which is 15%, a recurrent laryngeal nerve about 1.8%, and a pneumothorax up to about 6%. And obviously, since we depend, when you do a landmark technique, we always depend on a volume to bring about the success of the block. So there is no doubt that you can get all these complications. So would you really call the landmark technique as an effective technique? So I wouldn't really call that, though you might have a good success rate, but the chance of complications is also high. So today, of course, we will rule out the landmark techniques, and we will stick to mainly the PNS and the ultrasound guided. So before we know what an effective block is, we should also know how to define a failed block. Now, there are several studies which have defined failed block in various methodologies. And this one by Yazar et al. Has defined the failed block as as it being of giving general anesthesia just after the surgical incision, a use of opioid intravenous analgesics, which is greater or equal to 100 micrograms of fentanyl, rescue peripheral nerve block being performed after the completion of the initial block, or a surgeon infiltration of local anesthetic into the site of the surgery. But this, I think, is a little too harsh on the anesthesiologist. And this sometimes does not really define a failed block adequately. So if you look at another study, which of course, this is in the critical care case reports, of course, here it looked at defining a failed block in a different manner, where it said that it is a total failure. Suppose it's a total failure, you can call where the bolus of local anesthetic completely misses the target and the surgery cannot proceed. That means you have to convert. An incomplete block is when the patient has numbness in the area of the nerve distribution, but it is not adequate for the surgical incision. Now, a patchy block is one in which some areas of the plexus have escaped. A wear-off block or a secondary block is where if a surgeon takes a long time to do the surgery and the block duration outlasts it. So it can be called as a secondary block. A misdirected block is where a part or whole of the drug is injected into a neighboring structure, which is in a different facial plane or a muscular or a press or into a vessel also. So if you do not know the type of surgery or the area of surgery, so you may end up blocking the wrong nerve or for the planned surgery. So all this could be a more ideal way of defining a failed block. So using this definition, a large landmark study was done, and it's found that the reasons for failed block could be many. One could be there could be preoperative anxiety, which is natural amongst all our patients. Obese patients generally have tendency to have a failed block. What is the approach that you're using? Because if you're using the axillary approach and you have not blocked all the terminal branches, then you might need you might lose, or certain dermatomes might be escaping, as a result of which the block might fail. If you have used a small needle in a transarterial technique, if you're using it blind, so that can cause a failed block. What is the threshold of the peripheral nerve stimulator that you're using? The volume and the dose of the local anesthetic can also cause a failed block. What are the number of injections that you're giving? And last but not the least, the most important is the operator training and experience. These all would contribute to a failed block. So what are the failure rates and the complication rates, which are mentioned? The peripheral nerve stimulator guided blocks, the failure rates are as high as 11.3 to 12%. The ultrasound blocks, the failure rates amongst trainees has gone down to about 6.4%. And the axillary block with the ultrasound or the dual technique has a very high success rate of more than 92%. Now, when we look at factors associated with failed brachial plexus for upper limb surgery, you will find that whenever you do a block in which a dual stimulation is used, that was a dual guidance is used, that means you use both nerve stimulator and an ultrasonography, the number of failed blocks has gone down to 0. And as I said before, as you move down from the cephalate to the distal areas, the number of failures tend to increase, because then the branching out takes place and you must be able to block all the branches, otherwise the failure might occur. And in general, one would not link the failed blocks with the volume of drug use, because drug volumes of about 20 to 65 mLs have been used in this study, but failure has not found definitive any correlation with the volume of drug used. Amongst the operator, a regional anesthesiologist or an anesthesiologist trained in regional anesthesia obviously had a higher degree of success rate as compared to a novice. So here are some tips to avoid a block failure, especially if you're doing a PNS guided interscalene block. So what do? when you suppose there is a local twitch of the neck muscles, here, of course, it means that the stimulation of the anterior scalene and sternocleidomastoid is taking place. So you're in the wrong plane. You need to withdraw the needle and reinsert the needle 15 degrees posterior. Suppose the needle contacts the bone. This is usually the trans process. So you need to move the needle a little anteriorly. Suppose there are twitches of the diaphragm. Here, the needle is, this is stimulation of the phrenic nerve. So the needle is too medial and anterior, and therefore you need to withdraw the needle and insert it posterior and lateral. If there is blood in the tubing, again, you're in a vessel. So you need to withdraw the needle completely and put in pressure. Suppose there is stimulation of the pectoralis muscle, then you can accept it and inject the local anesthetic. Or if there is a twitch of the pectoral, deltoid, triceps, and the hand, etc., you can inject the drug, and then you will get a successful block. So if you're doing a supraclavicular block of PNS guided, one should keep in mind that you should never put the needle any deeper than 2.5 centimeters if you do not get any twitch from the brachial plexus. And once the trunk is usually in contiguous, if you look at it in an anatomical cross section or on a dissection table, you'll find that all the trunks lie like the tiles on a pavement. So a stimulation of one trunk followed by the other should be in a contiguous fashion. And if you miss one kind of stimulation, then you should obviously redirect the needle. And the margin of safety is about 2.5 centimeters lateral to the insertion of sternocleidomastoid, because you're well away from the tomb of the diaphragm, and you do not have a chance to cause the pneumothorax. So if you're doing an ultrasound guided block, the knowledge of the dermatome, myotome, and the osteotome is very, very important. You should also know what the surgical procedure is and where the surgical incision is going to be. You can use your supplementary blocks. You should know where the primary block sparing areas are. Good ergonomics are very, very important. Your operator, the patient, and the machine should be in a single line so as to not obstruct the field of vision. They should have accurate deposition of the local anesthetic. The time interval for the onset of block is very, very important. You must allow at least 30 minutes for the block to take onset, because surgeons trying to, really rush you is not very, very good. And last but not the least, training is very, very important. And once you train well, you execute well. So what do you do if a nerve block has failed? So you have done your nerve block, you've given the primary block, you found your sparing areas, you've given your supplementary block, and now is the time to assess the block. So once you assess the block, the patient complains of some unrelated sensations, which could be tingling or vibration, and you do not find any objective signs of block failure. That means some amount of motor is coming, your adequate 30 minutes has not passed. You wait for the 30 minutes to pass, and there is some objective signs of no objective signs are there, then you can just, go and assure the patient and give some anxiolysis. Your block will take effect. However, if there is complete failure or partial block failure, then you have to look at what your drug safety margin is. Suppose it is not exceeded and time is available, then you can repeat the block or do a rescue block. Suppose your drug safety margin has exceeded, then you'll have to convert to general anesthesia. However, if there is secondary block failure, that means the surgery has prolonged beyond the time of the block, then you will have to convert the patient to general anesthesia. So, as you know, whether you want to make a block effective or you want to make avoid any sort of complications, very, very important is to understand the anatomy of the brachial plexus. So all your complications and your success rates comes from your accurate knowledge of, as I said, the anatomy of the area. So if you look at what the interscalene level is, you will find that in close proximity is the phrenic nerve, which lies about the anterior and medial to the brachial plexus, and therefore the chance of phrenic nerve block is very, very important. And the other thing that lies close to the roots is the vertebral artery. So one must be very, very careful in using these areas, especially if you're doing a PNS guided block or a blind block. in ultrasound, of course, you can see your different structures, and I will come to that later on. If you're doing the supraclavicular, the infraclavicular brachial plexus block, one must be very aware of the artery and where the pleural duo is. So all these will improve your success rate and also decrease your complications. Again, if you come to the axillary brachial plexus block, you will find the medial nerve and the radial nerve and the ulnar nerve are quite proximal to both the axillary artery and the axillary vein. Also, the musculocutaneous nerve lies in the sheath away from the primary nerve. So you need to, for getting a good block, you need to block all the components, and then only your failure rates will decrease. And one must be aware of all the blood vessels which are close to the various nerves. So as a result, to avoid complications. So how do you now minimize complications? Now that we've talked about an effective block, let us now discuss of how to decrease the complications. So before we try and decrease complications, we must understand what are the different complications that you may encounter. So for phrenic nerve block is one of the most common complications, especially when the interscalene block is given. The Horner syndrome is another complication. The recurrent laryngeal nerve paralysis is a possibility. Inadvertent arterial puncture is very, very important complication because most of the plexus at all times is lies close to a vascular bundle. The nerve injury is a very, very difficult complications, having medical legal implications also. Pneumothorax is also one other important complication. Local anesthetic systemic toxicity, though rare, but very fatal. Infections and hematoma are other complications that one can encounter. So at various levels, different types of complications occur. Like I said in my previous slide, interscalene will generally cause phrenic nerve palsy, Horner syndrome, vertebral artery injection. At supraclavicular level, one has to be very careful about pneumothorax. At the infraclavicular level, again, pneumothorax. At the axillary level, hematoma formation and intravascular injections are very, very common. So let us discuss all the complications one by one. So what does the phrenic nerve palsy lead to? The phrenic nerve palsy will lead to ipsilateral hemidiaphragmatic paralysis, which is very, very important complication. This phrenic nerve palsy is usually transient in nature. It is most common in the interscalene block, has a very high incidence of about 36%, 67% with the landmark technique, and almost 100% with the PNS guided technique. Whenever a volume of more than 20 ml of drug is used, then the chances of an ipsilateral hemidiaphragmatic paralysis is 100%. Sometimes you might have a persistent phrenic nerve palsy, which is 1 in 100 to 1 in 2000, and it can be because of a direct needle trauma. Intraneural injection or a direct needle trauma. So, usually, when you encounter transient phrenic nerve palsy, it usually is very well tolerated by a healthy individual. But in high-risk groups, it can cause a persistent decrease in FEV1 by about 16 to 40%, and FVC by 23 to 27%, and a PEFR by less than 45%. The SpO2, however, might remain unchanged. The patients might have clinical signs of either they may be asymptomatic or they may be dyspneic, and supplemental oxygen may be required. But respiratory compromise is possible in patients with compromised lung, especially in COPD, post-pneumonectomy, and morbidly obese patients. And these are the patients that we need to be very, very careful about when we are using an interscalene block in such individuals. There are several case reports in literature wherein persistent diaphragmatic palsy has been associated with the interscalene nerve block. So let us see why this happens. You'll find here that the yellow thing here is the phrenic nerve, and you can see that it is anterior to and it is medial to the C5, C6 roots. here, if you look at it, if you normally you would place your needle at this level between the C5 and the C6 roots, and the phrenic nerve is this yellow marker over here. And as you move down, suppose you move further, caudad, this phrenic nerve tends to move away from the plexus. So the chance of blocking the nerve at a much caudad level, blocking the phrenic nerve when you give the block at a caudad level is very, very less. So if you move down and you do not inject at the level of C5 and C6, then you would stand much better chance of not blocking the phrenic nerve. Other strategies which you can use to decrease the hemidiaphragmatic palsy is to decrease the drug volume. Because if you decrease a drug volume of less than 20 ml, the chance is less. But studies have shown that using an ultrasound guidance and a drug volume of 10%, the incidence still is about 60%. However, if you use a drug volume of 5%, the 5 ml, the incidence has decreased to 27%, but the analgesia is very, very poor. So the jury is still out on what is the volume to be used in the interscalene block to prevent the hemidiaphragmatic paralysis. Now, if you lower the drug concentration, then also you can decrease the hemidiaphragmatic, the phrenic nerve palsy, but again, you will compromise with the decreased analgesia duration. The injection technique should be slow, low pressure injection, small aliquots, as this will limit the spread of the drug in, and an extrafacial injection. So as a result, to decrease the phrenic nerve palsy. But of all the other techniques, the most important techniques is you can modify the level at which you give your brachial plexus block. Some of the strategies to decrease the HTP is you can perform a C7 root block. Now, C7 root block, like I said before, you will find the C5 and C6 over here. The C7 root block is over here. You can give an isolated C7 root block, but one must be very, very careful because the vertebral artery is right next to the C7 root. So there is a chance. And however, it does not decrease the hemidiaphragmatic palsy 100%. Again, you can move to the supraclavicular plexus, but does it provide adequate analgesia in the shoulder region is the question. So the most common block that is used now is the upper trunk block. The upper trunk block is the blockage of isolated block of the superior trunk only, as it is just formed under the belly of the omohyoid muscle. And here the hemidiaphragmatic palsy decreases to about 4%. And one can also do the anterior suprascapular nerve block, isolated anterior suprascapular nerve block, as it comes out very at the beginning of the formation of the upper trunk from under the belly of the omohyoid, as you can see here, which is marked by a black asterisk. But blockage of anterior suprascapular nerve, isolated block, the hemidiaphragmatic palsy has not been studied yet. Costoclavicular nerve block is another strategy which can be done, which is shown to have a hemidiaphragmatic palsy of about 0%, but technically it is much more difficult because you're tackling the cords behind the clavicle, and accidental intravascular injection and pneumothorax are a possibility. So one must be able to choose their technique and their volume very, very carefully in order to decrease the chance of isolated phrenic nerve palsy. Now, pneumothorax is the next common complication that one encounters, which is most common with supraclavicular and infraclavicular blocks. The incidence ranges from about 0.5 to 6%. Now, symptomatic pneumothorax, however, is less than 3%. The onset of symptoms might sometimes be delayed up to 72 hours. Mostly patients will complain of chest pain, dyspnea, and when symptoms appear, usually 20% pneumothorax has already happened. Now, diagnosis is by a chest X-ray and upright precision, and the jury is still out on the fact whether a routine post-op post-procedure chest X-ray should be done, because in delayed pneumothorax, immediate post-operative chest X-ray is not going to give you much idea. CT scan can be done in patients with high index of suspicion. However, a point of care ultrasonogram is a gold standard, which has a negative predictive value of about 100% and a specificity of about 94%. Usually, a block failure results, and you have to convert to a general anesthesia. And when one does so, one must avoid nitrous oxide in your anesthetic practice there. So, there are again several case reports with whether it is supraclavicular or infraclavicular, you can get a brachial plexus block, which can be either, you can get a pneumothorax, which can be either early or delayed. Now, what are the strategies to minimize pneumothorax? Now, in landmark technique, I said we will not be discussing, but most practitioners do use. One must be very, very careful about where you insert your needle in. It should be about 2.5 centimeters lateral to the clavicular head of the sternocleidomastoid, and the needle direction should always be lateral and posterior, because if you turn your needle medial, you might be able to hit the dune of the diaphragm, which is quite medial in this case. Similarly, it goes without saying the direction of the needle should be the same with the PNS guided. However, the ultrasonogram has given the advantage of seeing the pleural margin right underneath the first rib, where you can quietly differentiate the first rib. And this is the line of no passage. Here is something that you should never be crossing. And beyond this line, one should never be able to, one should not be crossing so as to not breach the pleura. So in a small pneumothorax, usually there is spontaneous resolution, and some patients might require oxygen supplementation. But when the lung has collapsed to more than 25%, then an ICD insertion is indicated. Now, nerve injury, as I said, is one of the most dreaded complications and also has a lot of medical legal implications. The incidence of nerve injury following brachial plexus block ranges from 0.2 to about 19%. Usually, the nerve injury can range from a transient neurological symptom to a permanent nerve damage, and usually the type of damage depends upon the method of localization. Suppose you have done by a paresthesia method, then the chance of nerve injury is much, much higher as compared to a PNS or a USG. And most commonly, it happens in the enterscalene or the axillary brachial plexus. The symptoms could be from persistent paresthesia or postoperative neurological symptoms, or to neuropraxia, exontomesis, and neurotomesis. Now, permanent injury incidence is about 0.014% to 0.04%, and the etiology could be mechanical damage, which is due to a high intraneural pressure due to injection of local anesthetic intraneurally, or a hematoma. Then sometimes it could be due to chemical injury also because of local anesthetics and adjuvants. Now, let us understand the mechanism of nerve injury. So here on the left side, we have this diagram of how a nerve generally looks like. So if you inject here around the epineurium, that is, your block is bound to fail because the drug does not need to does have to cross this area. But perineurally or extraneurally, if you inject, the chance of nerve injury is very, very less as compared to intraneural. So in the intraneural region, if you inject into the fascicles, the chance of nerve injury is very, very high, and as compared to extrafascicular, which is in between the fascicles. But in the brachial plexus block, one must, so if you look at the pictures on the right side, so the one which is green is the ideal. The yellow is okay, you will not get a nerve injury, but your block will take time to affect. And the red one is one which is intraneural and should never be injected. So your needle placements should be like it is in the green one in all the three diagrams. And in the brachial plexus, one must remember that there is a sheath of prevertebral fossa, like you can see over here, the facial layer is over here. So a layer of prevertebral fascia is here. So you must breach this prevertebral fascia. So if your needle goes beyond the prevertebral fascia, you're bound to fail, and you must breach this prevertebral fascia for drug injection for your block to be effective. Now, how do you prevent nerve injury? So localization technique is one of the most important thing. Deliberately seeking paresthesia is not recommended at all. When you're using a peripheral nerve stimulator, your current should be low, about 0.8 to 0.8 milliamperes, and your pulse should be about 0.1 milliseconds. A USG is one of the most important methodologies in order to prevent the nerve injury, where you can visualize the needle tip. It in plain echogenic needle, bevel should be up, and you must do a hydrodissection to see where your tip of needle is. Now, injection pressure monitoring is very, very important. A low opening injection pressure should be there of less than 15 psi. On the right-hand side, you can see a diagram, which is a very simple device which you can attach to your syringe and your connector, and it will give you your injection pressure. Using short bevel blunt needles, using a mild local anesthetic is always better. Adjuvants, you can use epinephrine at a concentration of 2.5 microgram per ml, dexamethasone, clonidine, neostigmine, opioids. Dexmedetomidine is neuroprotective. Ketamine and midazolam, not so good. Preferably, one should always block an awake responsive patient who can give you a jump if you accidentally hit a nerve, and avoid a patient with pre-existing neuropathy. If at all you have to give, then you must use an ultrasound. You must not use epinephrine, and you should decrease the local anesthetic dose. And most importantly, you must stop if the injection is painful. If you're injecting and the patient is complaining of pain, one must stop the injection there and there. So how do you manage once you suspect a nerve injury? So how do you suspect a nerve injury? If there is a new onset of pain, weakness, numbness, paresthesia, or an abnormal sensation, and the effect is lasting beyond the duration of the specific block. So these are the two things that can give you that there is a chance of nerve injury. So you must review the medical history charts and everything. You must review the anesthetic reports. You must see the drug chart. You must do a proper clinical examination and a neurological examination. Suppose you see that there is a space occupying lesion, then immediately it must be treated as an emergency. So if you find that the symptoms are mild or resolving, then you must reassure the patient and review the patient after 4 weeks. If there is persistent symptoms, then you must continue to do a neurological referral and do other neuroimaging studies, including a MRI and a nerve conduction study. However, if you have a complete or a progressive neurological deficit, one must treat it as urgently as possible. A multidisciplinary team should be taking care of the patient, and you must immediately do all the imaging studies. You must come to a definitive diagnosis. If a surgical intervention is required, in case there is a hematoma, it must be done immediately. And above all, you must keep the patient informed and follow up. So another dreaded complication is accidental intravascular injection or local anesthetic systemic toxicity. So these are the two most important reasons. And why we must know, because most of the nerves are associated with a vascular bundle, and we are placing our needles very close to arteries and veins. And as a result, we might get a accidental intravascular injection. So how do you minimize it? You must always be looking for a flash, and you must aspirate every 2 to 3 ml. If you use an ultrasound and you localize your needle accurately, then you will be able to avoid it. You must scan before needling. A color Doppler is must in order to localize all the small blood vessels that are in and around the nerve plexus. You must locate the needle tip before injection. You must also look for the spread of the drug, very important. Suppose that you cannot localize your drug, do not inject, because your needle tip might be intravascular and your blood flow is taking away your drug. So you can test with a saline injection if you're not so sure. And you can use a color Doppler to localize the drug also. So adding epinephrine is also a possibility. So it can give you a increase in heart rate if at all you are intravascular. So again, the local anesthetic systemic toxicity is very much dependent on the dose of the drug that you're giving, and the maximum dose of the drug changes from with the height of the patient, the weight of the patient, the age of the patient, and the size of the limb to be blocked. But in general, we will go with the established drugs, established doses, that is lidocaine about 4.5 milligram per kg body weight and 7 milligram with epinephrine, and bupivacaine and ropivacaine about 3 milligram per kg body weight. And the incidence of systemic toxicity last is about 1.8 times per 1,000 nerve blocks. Caution must be exercised in patients who have some renal disease, pregnancy, and liver diseases, etc., where the dose must be accurately reduced. And for last, the symptoms could be either immediate or it could be delayed. So what are the symptoms that you can get? Neurological symptoms usually are the most common, that is seizures and agitation or loss of consciousness. Prodromal symptoms or early symptoms would be perioral paresthesia, metallic taste, and tinnitus. But suddenly, usually 40% of last usually will present as a sudden rapid onset seizure, and then it progresses to cardiac arrest. And if a high dose of local anesthetic has inadvertently gone inside an intravascular area, then the CNS symptoms may be absent and you might get the manifestation of serious toxicity immediately. So serious toxicities would be heart conduction abnormalities, ECG changes could be there, depression of the spontaneous pacemaker activity leading to a systole, and a cardiogenic shock and a refractory hypotension, which must be immediately treated. So this is the last protocol, which should be hanging in every block room. It is not necessary to remember, and every person who is working in the block room should be aware of where your intralipid is kept. Your intralipid should be present inside the operation theater at the time of giving your blocks. So every day it must be a part of your checklist in your resuscitation trolley, in your crash cart, whether in your block room, whether the lipid emulsion is available or not. So this chart must be hanging right in front of your eyes while you're blocking, so as to immediately start. And the only success rate happens if you have done it in the first 1 minute, and that is when you can try and bring your patient back. So the other important complication is accidental central neuraxial block, or Horner's syndrome, and a recurrent laryngeal nerve palsy. These are rare, but nevertheless very important complications. And these are very common with the interscalene block. This is because, the sheath is quite contiguous. The dural sleeve usually extends beyond 8 centimeters of the intervertebral foramina. If it extends, then it can be punctured, and a subperineural spread can occur. Total spinal has also been reported, and a Horner's syndrome and recurrent laryngeal nerve palsy, the rates are between 18.5% to 3%. So one must not really be very cautious in giving blocks. So these should not be done in corridors without adequate painting and draping, and one must be doing it in a proper block room with all your resuscitating equipments available. If you're using an ultrasound, the proper sterile practices, needling, your probe cover, everything must be practiced, because in this day and age, infection is one of the most dreaded complications that can occur, because we, as intervention, we do so many interventions in the operation theater. Again, lastly, training and practice. I cannot emphasize the importance of training and practice while performing these blocks. And these can come through videos, with observers, with demonstrations, with simulation, and practice again with a trained teacher. That is when you can improve your accuracy and make your brachial plexus block truly bulletproof. Last but not the least, one cannot emphasize the importance of documentation, a proper informed consent, a proper timeout procedure, as to that you're blocking the right area, the right limb, and again the documentation of the block and what guidance you have used, what drug you have used, what is the volume that you've given, is very, very important, and can give you a lot of help in any medical legal situation. So finally, let us see what are the takeaways. Landmark technique of brachial plexus block is fast becoming obsolete. The block failure and complications are higher with the landmark method. The use of dual modality, the ultrasound and the peripheral nerve stimulator is the preferred method for localization. The dual method decreases block failure and complication rates. Eliciting paresthesia is an absolute no-no. Caution when that ultrasound is not the answer to all maladies, but definitely it minimizes complications. It has a learning curve, so training is important. Complications do occur. Identify early and manage. Informed consent and documentation are a must. And lastly, practice makes a man, if not perfect, at least safe. And thank you so much for a patient hearing. I can take any questions that anybody would like to ask. Thank you so much.
Thank you. Thank you, madam. Very, very good presentation.
Thank you, sir.
And all the slides are very clear and very updated slides are there. Slides are very good, and the way they are presented are very nice.
Thank you, sir.
Clear. Thank you, madam. Ramakrishna, carry on.
It was a elaborative presentation and very well presented. Srilata?
Yeah.
Yeah. Are there any questions in the chat box?
There are no questions per se, but yeah, Dr. Vidya says very, very informative. And I think, like I said in the start now, that most of the questions, the common questions in PG we encounter, and most of them we have covered, like complications of brachial plexus block, all the different techniques of brachial plexus block. And the other one is the last. The way Vidya has done it is like very, very justifiable. And I think the PG students must come out with all the questions. This is the most common question you get encounter. Practicality and theoretical, both are important here. And one question from me, like, Vidyadik, like, do you practice the superior trunk block?
Yes, we do practice the superior trunk block. About 3 or 4 years ago, 5 years ago is when I started doing the ultrasound guided blocks, and I was regularly doing the interscalene block. And naturally, I have noticed most of the patients, if you're using a good volume of more than 15 ml, you will get a hemidiaphragmatic palsy. And of course, patients do complain of difficulty in breathing and drop. So we slowly and steadily, we decrease the volume. And now we have, with more, improved scanning techniques and our technique getting more refined. So we are we have started doing the upper trunk blocks. And also one of my DND students is also pursuing a thesis on that. And we are doing a volumetry study currently as to what would be the ideal volume to prevent the hemidiaphragmatic block. So that is something that is going on at our institute right now.
Very interesting.
Madam, what's your opinion on bilateral brachial block?
So that's an absolute no. Absolute no. No bilaterals. I just forgot to mention that in my slides. No bilaterals.
Yeah.
With ultrasound coming up, no?
No,
No. I
wouldn't do that. With ultrasound, the advantage that you have is you can go ahead and block so many, peripheral nerves you can block. The days are gone when we used to do chhati thokke, we used to tell ki, acha, I did my surgery in brachial blocks. That is not the right way to go now. So the block is for the analgesia. The surgery you can you can give a light general anesthesia, you can use TIVA, you can use Dexmed, you can use a Dexmed infusion, you can do a lot of things to keep your patient steady during surgery. And if at all, suppose I need to do both wrists, then or an elbow and a wrist, I would go for a wrist block one place and go do a elbow block the other side, and then put the patient in sedation and a Dexmed infusion and do that. But I would never, as long as I'm able to, using the ultrasound, I'm able to control the volume of the drug that I'm giving. So I do not exceed the maximum limit or the drug dosage. So I wouldn't advocate a bilateral brachial anyway, not at all. Because
Madam,
even in the best of hands, you just might go ahead and puncture the pleura on both sides. Then you think what you're going to do.
Bilateral phrenic nerve palsy also common.
Yes, bilateral phrenic
nerve. Okay, madam, any experience like we maybe 20 years back we used to keep one IV cannula and continuous brachial block one side.
Yes.
Is there
Yes.
any means improvement in such a things like
So,
continuous brachial block?
yeah, there are lots of physicians practicing. I personally do not
Did you get
do
my
a
point?
continuous brachial plexus at all, because adjuvants are good enough and they give you a long duration of analgesia. You really do not need a lot of continuous. Personally, I do not. Yeah, personally, I do not do the continuous blocks, especially brachial. I do not do. I might put a catheter in the adductor canal for a TKR post TKR patient, but I generally do not do continuous brachial.
PGs, any questions, any queries from you? They don't have any queries. I think everyone has become an expert in that.
Expert, yes, because.
But I would say it's very, very good and very, very informative. And the other thing important is documentation. As you said, the documentation even of the block and also of the neuropathies the patient is having is very, very important to even in the post-op period, so that you have a baseline, what is the neuropathy before and what has happened afterwards. So that is
Yes,
very, very important.
definitely. And with the number of medical legal situations coming up our way, it is very, very important to document pre and post. And also that is something that is going, your documentation is something that is going to save your back. That is all. And one cannot emphasize more about correctly documenting a good informed consent. Very, very important. And also I cannot less emphasize about the timeout procedure, which really needs to be spot on, especially now that the concept of block rooms are there, and there is the person is to be anesthetized by a different person, block is supposed to be given by a different person, and you have all those checks and balances have to be in place in order to get a good success.
Yeah, one question again from me, like how frequently I've encountered LAST and how many times like you have used this interlipid emulsions?
So personally speaking, I have not encountered LAST, thankfully, till date, not encountered LAST. So I wouldn't, I have really not tried theoretically everything about LAST. And I think if you have LAST, yeah, we did. I remember long time ago, we did have a patient with accidental intravascular injection, and that patient had neurological complications, not up to the cardiovascular stage. So, but once it becomes cardiovascular, I think you have to be very, very quick. Otherwise, the chances of reviving the patient is going to be less than zero, I think.
So is intralipid emulsion is available over?
Yes,
yeah.
we keep in our block room intralipid. Yes, very much.
It's not available in our institute. That's it. Though we are not encountered LAST still, no. But
no. But I think even if we have not encountered, it is safe to keep. Intralipid is something which everybody uses in the ICUs. A bottle in the OT is very, very.
We can. Ramakrishna sir, Ratnakar, Dr. Ratnakar, Dr. Ramakrishna. Anything else you want to add?
I think you have to unmute, Dr. Ratnakar, unmute.
Deepraj sir.
Madam, Aarti madam. Dr. Aarti madam.
Yes, sir.
Yeah, most of the times our friends or colleagues, they'll be asking before doing any exercise, what is the whether you have to take any other liquids or can you do it soon after breakfast or something like related to full stomach, like.
Yes.
So
Sir, actually it depends again what kind of exercises you are doing. If you are going for ideally you should be an empty stomach if you are going for yoga. But yes, if you are going for walk, run, you can have something pre-workout, because these are energy consuming exercises. You need a good energy for these strenuous exercises. So even before going for weight training exercises, that is gym, for walking, for running, For cycling, before workout, during workout, and post workout, you have to take care of your nutrition. So like if you're used to fasted state workout, you can go for fasted. But if you're not used to, or if you're planning for long duration workout, then you need to supplement. Like for marathons, we used to we do it routinely. I take either banana or some sandwich or some ghee, that dry fruit laddu, or ready-made gels are there available there, or dates and almonds. We take half an hour to 45 minutes before our run, and we focus on our hydration in electrolytes also. So we take lot of electrolytes even a week before a marathon, or if we are planning for long runs on Sundays or
In
any other
between.
day, we consume some kind of
Absolutely.
nutrients in between also. Like we carry banana, dates, almonds, and energal with us for our long runs. So yes, for yoga, you should be empty stomach. You should not eat anything 2 to 3 hours before workout. But if you are feeling low with energy, you can go for some dry
Small.
fruits or some ORS and something, and you can start with your workout. You don't need to be a totally this thing empty stomach if you are feeling low with energy. But obviously, with a breakfast and all, you can't go for yoga. But yes, for running and all, again, I said that you should have it 30 to 45 minutes prior to your exercise. But there should be
Thank you.
time for it should get digested, and you should not have a full stomach or like regurgitation while running or walking. It should give time to break it down.
Thank you. Thank you.
Yes.
Okay. Shall we conclude?
Yeah, and also that we should not over-exercise, because I think you've got good number of news recently.
Yeah,
that,
yeah, that's true.
Incidents
Some
which have happened.
sudden collapse
Yeah.
while
The
doing
sleep is
vigorous
important.
exercise.
Sleep is important, and also good exercise is important rather than over-exercising.
There is
Balance.
no limit for the over exercising. Like if WHO says that 30-minute exercise 5 days a week is enough, so it's just 150. So if you go for marathon, if you go for Ironman or this thing, it's all a passion, and they all train accordingly. So the incidences that incidences are common everywhere. It's not only with the gym or running or anything. This happens if you push beyond your limits, if you don't follow all other things. As I said, that for healthy lifestyle, it's not only about the exercise. You have to take care about your nutrition, about your sleep, about your vitamin levels, about your regular checkup of your hypertension, your treadmill test, any ECG changes in the working heart, and all other parameters. So you have to look after your vitamin D levels, your folate levels, all other things also. So if everything falls, then only you are fit. It's not only about the diet and exercise, but you have to take care of all other things also. And heart rate monitoring again. When now we are runners, we use watch and heart rate monitor, that is chest strap we use. Or even if you don't use that, then you should go for natural feel, that you should enjoy your running. You should not be out of breath all the time. It's like you should be able to listen to the bird's voice. You should be able to listen to the your shoe tapping and all. So you should be aware of the surrounding. You should not go out of the breath. So this way you will keep your heart rate under control, and such untoward incidences will be avoided.
Thanks.
Thank you, Dr. Aarti and Dr. Srividya. It's nice discussions and nice presentations.
Very nice evening.
Yeah.
Thank you. Thank you both
And
the speakers.
Lalit sir asked me about the music while walking.
Yeah.
I actually don't recommend music also, because again the same thing that we say, that when you run or walk, you should focus on your breathing. You should focus that you are breathing nasally, so that air will be slowly inhale and slowly exhale. You will not again go out of the breath. Focus on abdominal breathing. Focus on your stride. Focus on your foot strike. Like in running, we focus on the mid foot strike. So all these parameters you will focus if you won't listen to the music. Another thing about the traffic also, if you are engaged with music, and if the incidences happens because of that also, so it's always better to run without music or to walk without music and enjoy.
Because nowadays,
Madam, traffic and
because
guidance.
nowadays who are doing jogging on something, they are putting the earphones. And
But
music is there.
we recommend everyone that don't listen to the music while running or walking. Better to run without that. Enjoy the me time. Enjoy the moment. Feel the
Of
breeze.
traffic and straight.
And it's for yourself also, na? Because then you will have a good control on your movement also.
Thank you, Dr. Ramakrishna. Conclude this session.
Thank you, Dr. Aarti and Dr. Srividya. Silata, shall we conclude?
Yeah, we'll conclude. Thank you, Dr. Aarti, Dr. Srividya, Dr. Ramakrishna.
Thank you everyone for giving us this opportunity.
Dr. Lali.
Thank you so much for giving us this opportunity. It was great to see all of you all, and hope to have many more interactions like this.
Thank you, madam.
Thank you.
Thank you.
Good night. Good night, everyone.
Good night. Good night,
Good
everyone.
night. Good night,
Thank
everyone.
you.
Thank you, everyone.